What is up, Sleep Tribe? Welcome to a brand new episode of the Healthy Sleep Revolution podcast. Today, I have a guest that I was actually a little intimidated about having on. I have been following her on Twitter, and just the amount of knowledge that she drops is mind-boggling. It blows my mind, and I couldn't not have her on. So Dr. Lara Kierlin, did I say that right?
That's right.
It is such a pleasure to have you here today.
Thank you for having me.
And you are now double board certified, right, in adult psychiatry as well as sleep medicine. Is that correct?
That's correct. Yeah.
That is so amazing. When and where did that overlap happen? What prompted that?
I think my very last rotation in medical school, I was going into adult psychiatry. Actually, I thought I was going to be a child psychiatrist. Let's thank God that didn't happen in retrospect. And I did a sleep medicine rotation with the late Dr. Mark Mahowald at Hennepin County in Minnesota. And he was just a fantastic influence. The residents and fellows there were great. And I really was able to sort of see the overlap of psychiatric disorders and sleep disorders in that context, and kind of more specifically, neuroanatomy, neurophysiology, how the circuitry of sleep was almost the same as the circuitry of so many psychiatric disorders. So I went into residence knowing I was going to do sleep and was able to sort of tailor my residency doing rotations in CBT for insomnia, and just sleep medicine rotations so that I was ready for fellowship when that came later.
Wow, fascinating. So for our listeners, I know we kind of touched briefly upon who it is that mainly tunes into our podcast. Could you provide an overview of sleep disorders and the prevalence that you see within your specialty in the general population? Be it adults, be it children, whatever your demographic is.
Right. Sleep disorders are kind of tricky because they may not present. In my practice, I do sleep disorders in a very specialized way. So people come in knowing I do sleep and they present with the sleep disorder. But when you are in primary care, like going to your family doctor, a lot of times the sleep complaint is not going to be the first complaint. It might be something else. It might be depression. It may be anxiety. It may be high blood pressure in the case of sleep-related breathing disorder. So many things. But when a physician who's trained in at least ruling out sleep disorders as causes or contributors to these symptoms will really ask the questions about sleep pattern, sleep complaints, to really find out, is that something that is important that needs to be addressed? In the old days, like 10 years ago, people used to see sleep as sort of a secondary disorder, where if there was depression, the sleep disorder that came with it might be secondary to that. But we don't really do that anymore. We just say, no, don't wait to treat one, treat both at the same time, because they interact with each other.
Wow, fascinating. What are the most common symptoms that your patients are coming in with? Is it, and I know you said they mainly come to you with already knowing they have a sleep issue, but are there certain symptoms you're seeing more predominantly in conjunction with, that depression or any such thing? Could you touch upon that?
It's really kind of, I think, two groups, because people may have exhausted treatment with their primary care and I'm sort of the next level of care. I see kind of the really tough insomnia cases, the ones where anxiety is now driving the sleep disorder, or there's an underlying more complex sleep disorder that is fueling the sleep disturbance, such as what we call circadian rhythm disorders, where people may have kind of melatonin secretion patterns that are not the intermediate pattern, which is to say a person who will go to sleep every night at 10 p.m. and wake up feeling refreshed at 6 or 7 a.m. It might be a night owl. It might be a morning type. And so it looks like insomnia, but it's not exactly insomnia. So that's kind of one group. And then the other group is things like parasomnias, restless legs, people who have sleep apnea, who have insomnia on top of that, and the people who have what's called hypersomnia, where they're just sleepy all the time during the day. and no amount of sleep seems to help them.
Okay. What does diagnosis look like for these patients?
It's a lengthy process. And that's again, I don't fault primary care for not doing this. It's not really their role. They don't have an hour to spend to really tease apart the details, which is really necessary, of what the sleep complaint is. They're not going to do a morningness, eveningness questionnaire to really see what the person's circadian rhythm might be. You really have to ask about patterns of almost everything. Like one of the questions I ask is, take me through your day, because we know sleep disorders now are not just nighttime disorders, but they're disorders of wakefulness as well. So just really listening to the patient, because their treatment is going to be so individualized based on what their life is, what their needs are, what their biology is. There's just such an interplay of so many different factors.
And since you mentioned treatment, what are some of the most common treatments for this? And I know it could be pharmaceutical, it could be non-pharmaceutical. And I'm assuming, looking at your expressions, it's usually a combination. Would you mind touching upon that a little bit?
I mean, I really have seen such great effects, and the research bears this out. CBT for insomnia, when done correctly, is so helpful for so many types of these problems. And it's something people can do online now. The problem used to be that there was a shortage of providers to do this, but there are some pretty decent CBT for insomnia programs that can be done just on your own, where, as part of that online treatment, you may see a therapist at some point. But you can kind of do your own sleep diaries and kind of shift your sleep pattern a little bit and do the relaxation training that they prescribe. So I really like CBT for insomnia. And as an offshoot of that, there's some other forms of psychotherapy that can be helpful depending on what the sleep problem is, such as acceptance and commitment therapy. There's now a lot of research about that, especially for people who have a lot of anxiety relating to sleep. Which seems to be a very common thing, at least in my practice. People come in almost more worried about the doctor that they've seen has almost made them worry about their sleep. And so those are tricky. You have to deal with those a little different way.
Yeah. And as you were mentioning CBT, I was like, I know what I need to ask her. Would you go into CBT a little bit more into detail for our listeners that maybe are not familiar with what it is or don't even know what that is? Yes, it's cognitive behavioral therapy, but would you dive in a little bit deeper?
Yeah. So I think there's a common misconception maybe amongst the general public or prospective patients that it's sleep hygiene. And sleep hygiene is just really this very weak intervention where, the doctor may give you a sheet of paper with tips about your sleep. And it's like, who hasn't heard this? Like, okay, I'm not going to drink a pot of coffee within 2 hours of bed. Okay, I know this. And really research shows that doesn't work. And in my belief, I almost think it's harmful to prescribe solely sleep hygiene with no other intervention, because then you set up this expectation in the patient that, what am I doing wrong? I tried this and it didn't work. Now your anxiety is higher and you have more hyperarousal and you're not going to sleep well. So it's very irresponsible, I think, to just dole out that sheet of paper. And more involved is CBT for insomnia, which is kind of a very specialized program that combines methods of sleep restriction, which is where you really consolidate someone's sleep into a shorter period of time. Again, kind of going off this assumption that if this is a person who is in bed 9 hours a night and sleeping only 7 of those hours, they don't need to be in bed 9 hours a night. They need to be in bed closer to 7 hours because that's what they're doing. So you do the sleep restriction to increase what's called the sleep homeostat, the sleep drive, which is that buildup of sleepiness that occurs naturally in human beings the longer you're awake. And when you do that, you induce a type of sleep, which is called deep sleep or non-REM stage 3, which is very restorative. And it's very difficult to wake up from that type of sleep. So if you have a lot of hyperarousal, you're waking up checking the clock all the time. If you have deep sleep at the beginning of the night, you're less likely to wake up anyway and do those aberrant behaviors. So CBT for insomnia includes that as part of it. It includes really a relaxation training to reduce hyperarousal. And it includes just a basic regularity of your sleep pattern. It's really kind of on a higher level. I always look at it as you're trying to match that sleep drive, the sleepiness process, with your circadian drive, which again is very individualized based on the person. Their circadian window opens at a certain time based on their biology and based on inputs like light and darkness and meal times, regularity of that. But you want that to align with that sleepiness, that sleep drive. And then people sleep very well. But because of work, because of schedules in their life, they sometimes just have those misaligned. And in CBT for insomnia, you try to get those back together.
And how quickly do patients see results with CBT? Because obviously this is somebody that's exhausted.
Mm-hmm.
I know me, I want a magic pill, that magic wand that I want you to wave. What is realistic by way of how quickly do patients start to see any improvement or start to feel better with this?
It's so funny. Sometimes you just get lucky and you really find, okay, the sleep window is opening here for this person. We're going to schedule it around this window opening, this window closing, and you just align things right. And based on, you do psychoeducation at that first appointment. So they know what's controlling their sleep and they know what's not controlling their sleep. So they feel a little bit less like that they're exerting pressure on themselves, that they have performance anxiety. You take that away and show what the natural process is. And it's more that once you remove those barriers to that natural process occurring, I mean, we're mammals, we're made to sleep, but because of the way our minds work, we sometimes do things to prevent that from happening. So once you remove that, you can kind of expose the normal machinery of sleep in the person, and you can have them improve really rapidly. But I will say, improvement is not necessarily good sleep every night. Improvement is more often than not, decent regular sleep, but it's being able to sort of have your day and function well, no matter what happens, and not putting that pressure on yourself, just letting your biology do what it's supposed to do.
Yeah. Does this look different for children versus adults? Will you recommend CBT for children or even teenagers as well?
It's so hard because what you see in teenagers and adolescents is that period of time where they become that delayed circadian phase, the night owl type, and it becomes very complicated. So many kids go through this when they get into high school, and again, their biology is telling them you're not ready to sleep until like midnight or even past that, and it wants to stay in bed till 8 or 9. You can't do that. And on top of that, you have all of these obligations with school and social and sports that will take you into the night on weeknights. And so your routine is so broken down. Everything is working against you. And so you have to kind of impress upon them, this is something that you really need to focus on. It's important. You need to basically treat it like a diabetic treats their blood glucose and taking insulin. You need to really kind of be monitoring your schedules and prioritize your sleep like you never will have done in your life. And that's really hard for like a 16-year-old to hear and to do. So you have to get the parents involved, I think.
I completely understand that. I'm a mom of 2 teenage girls, 17 and 15, and this is my battle every night. There are times
so
when I'm like, you're still awake at 1 a.m., go to bed.
It's so hard. And I mean, it's the thing, you have to be so rigid behaviorally, and you have to be so consistent, because research shows that you even take 1 day, 2 days off, which is a weekend for these kids, and it's all gone. You have to start over. So it's just really, and I feel like maybe in the future, there might be pharmaceutical opportunities in this area, but I mean, who lobbies for teenage kids? Not very many people. They're not kind of old enough to, advocate for themselves. So, but maybe someday there'll be better interventions than just the behavioral and melatonin and the light and dark that we do now.
Yeah, considering we're ready to hand car keys to them at this point.
Absolutely. Yeah.
It's super scary. So how can people with sleep disorders and co-occurring psychiatric conditions best manage their symptoms and actually even improve sleep quality?
Well, honestly, like I said before, you don't do the thing where we're going to treat your depression and then your sleep will improve. It seems like it is much more effective, because of the bidirectional nature of these disorders, to treat them both at the same time. Just go ahead. You can do CBT for insomnia while you're treating depression and anxiety, either pharmacologically or with therapy of it on its own. And actually, very recent research has shown that if you do the CBT for insomnia, you really improve the baseline anxiety and depression. I mean, if you can have someone sleeping better and they have restorative sleep, they're just more rational people. And when you're rational, you do CBT better. So it's this kind of feedback loop where you just don't want to wait. You want to deal with the sleep. You want to treat it. and you want to do some of those interventions that may actually overlap into treatment of their psychiatric disorder.
Yeah. Do lifestyle factors play any role in all of this? Is there any benefits, diet, exercise, all of that? What are your thoughts with that?
Yeah, I mean, so my explanation for that to patients is that the whole goal, at least in treating insomnia and in fact, circadian rhythm disorders, is regularity as well as kind of energy expenditure, like healthy energy expenditure, which we know increases adenosine levels in the brain, kind of that chemical adenosine that helps our brain to feel sleepy, that builds up through the day. And finally, it reaches a breaking point and we actually feel that sleepy, that nodding off, and we go to sleep and have deep sleep because of it. And so exercise will help you to build that up, and cognitive activity will help to build that up. So I always tell people who have insomnia, the worst thing you can do is have a bad night of sleep and say, I don't feel like working out today. I don't feel like thinking. I just want to watch TV all day. It's like, no, you should do the opposite. Go out there, be active. And it serves two purposes. You're going to increase your adenosine. You're going to increase the chances that you're going to have a better night the next night. And you send the message to yourself that, this insomnia isn't everything. I can still function even on a bad night of sleep, maybe not at 100% level, but I can still do these things. And that reduces the anxiety about the next night or the next night.
Yeah, that's so counterintuitive because you're like, I didn't sleep well. I really should stay in bed and maybe get some rest. And yeah, let's flip that switch right there.
Yes.
Right there. Yeah. What, according to you, is the future of sleep research and treatment, especially in this realm? And what advancements do you see coming up in the upcoming
year? I would love to see. So first, definitely would like to see more research funding going to circadian rhythm disorders, because I really believe that when you uncover insomnia complaints, so frequently they end up being circadian rhythm disorders. But the interventions are very limited for that. So that would be my first kind of inclination for what might be around the corner. But also there may be interventions in the future for kind of being able to manipulate things like REM sleep and non-REM sleep, which are very interesting and may have a lot of potential for regulating people's the type of sleep they're having, not necessarily quantity, but what is the type of sleep they're having and will it serve a purpose? And we don't know really because we're still in the midst of uncovering what those stages do. And so I think that is maybe like a 10-year down the road goal of research is to kind of see if there are interventions for manipulating that cycle.
That would be so fascinating. As we wind up our little chat today, what are your top 3 tips that you always, be it parents, be it patients that you see? What are your top 3 tips for getting the best night's sleep that they could possibly try to get?
An old mentor of mine, she was Jennifer Martin, who I think is now the president of the AASM. She was so great. We were always just kind of brainstorming, how can we distill CBT for insomnia into like one statement? And she always kind of thought, if people just were told, no matter what happens, try to wake up at the same time every day. You can fix so many of the complaints, so many. And this is kind of something, it's a principle that is behind, like, if you're very jet lagged or you're traveling overseas, you really want to just try to get on their schedule and wake up at that same time every day and not have the fluctuation. It's really the variability that seems to cause problems in our sleep timing. So that really would be like number 1. And because of the patients I see, I think another tip is again, to not really stress sleep so much, because stress is it's a force that will not help sleep. By definition, you're trying to put force on a system that will not work if you put force on it. Sleep is something that just kind of comes to you. The more you try to make it happen, the less likely it is to happen. And so it's sort of that tip of just remember you're an animal and you're going to sleep at some time, even if it's a micro sleep. Your body wants to do it. So stop putting those barriers up so it can't do what it wants to do. And I don't know, I guess the third one is just kind of have patterns in your life. Try to kind of eat it around the same time, because we know circadian cycles are not just sleep related. Circadian cycles are everywhere, gastrointestinal, hormonal. So the more you can encourage just regularity in your life, the more that has a positive impact in your sleep.
Wow, good stuff. Good stuff. Before I let you go, how can our listeners learn more, connect with you, basically stalk you the way I do on Twitter?
Yeah, it's so funny. Yeah, I've had that Twitter account since the day I finished my fellowship, and I feel like almost every day I've had something. So it's good. It's like I get to do my own continuing medical education by reading articles every day, so I can do that. So they can look at my Twitter. It's either Portland Sleep MD or Portland Sleep Doc. I forget which one is used now. Or for appointments, I'm in Tennessee, licensed here. So if they need to see me, they can search for me on Psychology Today as the website, where you just put in my name and it'll have my contact information there.
Perfect. And we will have all of her contact information, her bio, and all the cool stuff that she does in the show notes for those that are listening in. Well, thank you so much for taking the time today I have to take a few minutes to process everything I've learned today from you. And I know our listeners have benefited as well. Thank you very much. And for those that are listening in, don't forget to share this episode if you know somebody that could benefit. I certainly know people that I'm going to be sharing this with, and I will see everybody next time.
Thank you.